thing. With the availability of Ozempic and Wegovy and Rybelsus in India, that is semaglutide is available in India, and it has got data in diabetes, it has got data in obesity, it has got data with cardiovascular risk reduction, renal risk reduction, and multiple mast cell. So if you are not suggesting this drug, for example, there's a person who cannot afford, a person who is not accepting this therapy, and if you are not suggesting, will it be a legal issue for a doctor when this drug is available, and also with the evidence available as this as a first line agent to be provided, and if you are not providing this agent and a person developing some complications after a few years and coming back and then questioning you, why? They can even go to the court, that why am I not provided with this drug 5 years ago? Can that happen to your doctor with this much of evidence?
Surely that's going to happen soon. It's like if a person has had a myocardial infarction and you're not going to give aspirin or you're not going to give beta blockers, there is a need to write down on the case sheet why you're not giving aspirin or beta blockers. So with the wealth of data that is available with these particular agents, especially in a person with established cardiovascular disease or mast cell or with CKD, I think it may be prudent to even say that the patient was counseled about giving this particular drug but has not been able to take because of XYZ reason.
AK Singh, your comments?
Yeah, I agree with what Dr. Santosh said. We must discuss, with the patient, given the data which we have. And perhaps this is a kind of negligence on our part if we don't discuss. Whether patient can afford or not is a completely secondary issue. But as you know, the current ADA, ESD algorithm do suggest us that when you treat diabetes, you need to discuss with the patient about the pros and cons of the drugs which we are using. So it's prudent to discuss that, look, this is the drug we have, this has got the data. Whether not prescribing the drug would translate into any legal consequence, that I exactly don't know. At least in our part of the world, our patients are not that much smart enough, but maybe if you are in United States, somebody can put you into a legal suit.
Absolutely. So the conversation is shifting from purely glycemic control to a holistic approach, and the patients, because the information is available in the public domain, so the patients are already aware. So they are proactively seeking treatment for diabetes and related issues. And then as AK Singh and Dr. Santosh said, now it is the era of a shared decision making. Now a couple of patients are waiting for you. So I will start with Dr. AK Singh first. A 37-year-old male comes for a consultation, and he has consulted AK Singh. After a couple of tests, he has gone through an executive checkup, and earlier he doesn't have any other disease, and he is not getting treated for any chronic disease at present, and he is obese as per the Indian standards, 26 kilogram per meter squared. A1C is very high at 8.9%. Fasting is high, postplan is 252, and other tests for renal and hepatic function, they remain normal. So my question to Dr. AK Singh is, you have decided to start him on 0.25, that is the first dose of Ozempic for the first 1 month. And you know that there are chances for a GI side effect. So what are the advices to be provided to the patient to prevent gastrointestinal side effects? So a very basic question, but very, very clinically relevant question.
Right. So, as you all know, by virtue of its mechanism of action, the GLP-1, receptor agonist would produce GI side effects. If you are using GLP-1 and your patient is not complaining of nausea and vomiting, perhaps you are not injecting GLP-1. You are injecting a water. So, the GLP-1, similarly, like if you are using a SGLT2 inhibitor in your diabetic patients and glucose is not positive in urine, you are not using a SGLT2 inhibitor. You are using a Sattu tablet to your patient, as simple as that. So the GLP-1 has got a GI side effect, is known to us. What we need to speak to our patient that, look, that's the reason why I'm starting with the smallest dose, so that you are accustomed to GI side effects. These GI side effects are not going to remain for entire life. Over the period of time, you will have a tachyphylaxis to those side effects. Secondly, when you are taking these injections, right, not to take those meals which tends to produce, late gastric emptying. You don't need to consume very high protein diet, high fatty diet. You take small meals, which will, because you know that the GLP-1 is going to delay your gastric emptying. So therefore, if you consume a very high calorie, high protein, fat diet coming from any marriage reception, you might tend to produce nausea and vomiting. So, try to be careful of these side effects. Not a rocket science. These are very simple things to advise to your patient. And, at least I would say that with a 0.25 milligram of semaglutide, because remember, when semaglutide was approved to be used in patients with type 2 diabetes, the dose recommendation was not 0.25 milligram. It was 0.5 milligram. Later on, we realized that if we further go down to 0.25 milligram, we can have even a smaller GI side effect. And therefore, the current recommendation is to start with 0.25 milligram. Earlier, it was 0.5 milligram. The reason being that if you are starting with a smaller dose, the GI side effects gets to be, lower over the time. The second advice I would suggest that there's no need to hurry, jump to the increase the dose. Although the paper suggests that after 1 month you shift to the 1.5 milligram, but many times I don't shift. If my patient complains of nausea, I continue on 0.25 milligram for next 1 month. This is not a 20-20 match. This is a test match. You play like Ravi Shastri for 5 days, make 5 runs. That's it. The match remains draw. So the GLP-1 is a long, run race. You don't need to be hurried to go too quickly to the highest dose. You can prolong the medications for a little longer period of time. Nobody will sue in the court. So if somebody is taking, say, 0.5 milligram of semaglutide for 1 month and he is having GI side effect, don't turn it to 1 milligram. You continue with the 5.5 milligram, but say another 1 month, say another 2 months, then you shift to 1 milligram. So, the lower you go, the longer you go, the larger is likely to get, enable your patient to continue with the GLP-1. These are some tips for the GLP-1.
Thank you very much. Fantastic. So the person has accepted the advices of Dr. A.K. Singh, and he has stepped up to 0.5 at the end of 1 month, and the glucose is gradually approaching acceptable levels, and he has lost around 6 kilogram body weight, and he is happy to continue with the weekly dose of Ozempic. And I have a question to Santosh. He has sent a text message a few days later stating that he has forgotten to inject a dose of Ozempic. He is reluctant to message A.K. Singh because he is afraid of A.K. Singh. So he has gone back to Santosh. But he will get back to A.K. Singh soon. But the question is, he has forgotten the dose of Ozempic. And what happens when a dose of Ozempic is missed? What is advice to be given, Dr. Santosh?
If you look at that cartoon of that person, he's most likely to get an executive health checkup, coming with his collar up like that, drinking one coffee and coming into your room. So yeah, I think he is definitely going to get scared with one of us. So so the label says that if you miss a dose, you for fewer than 5 days, then you can administer the missed dose immediately. For example, if a person is taking it every Sunday and the person has missed the dose up till Thursday or Friday, he can take the missed dose. But if it's already on the 6th or the 7th day, skip that dose and go to the next one. So this is what the label says. But of course, we can use our judgment. So it can be very simple. If a person is taking it every Sunday, has forgotten to take it on Sunday and has taken it on Wednesday, he might as well shift to every Wednesday after that also. But here we have to discuss on-label discussions, and this is what it says. Fewer than 5 days, administer the missed dose immediately, and again continue on the same Sunday only that the patient was taking. More than 5 days, skip that week, go back to the next dose on Sunday. Yeah, exactly. So if they have missed a dose, then they can have the dose the next day. But if they have skipped the dose for more than 5 days, then you can skip it, and then when you resume it, then start injecting based on the original schedule so that you won't miss it in future. So now let me move on to the case number 2. And this is a 49-year-old female. And this patient is referred by a cardiologist to Dr. A.K. Singh. And she had an MI, and that was a couple of months ago. And during the time of MI, she was diagnosed of diabetes and started on insulin and multiple therapies, but she was not comfortable with the medications for diabetes. It was not a convenient, comfortable regimen which was prescribed by the cardiologist, and that is why she has met an endocrinologist. The A1C is 9.1, the fasting is high, the postprandial is 206, the EGFR is 77, and the liver function is normal. And the question to A.K. Singh is,
Now she's initiated by you 0.25 milligrams to start with for the next 1 month. What advice need to be provided? Considering this picture, the cartoon, she doesn't appear to be that much overweight or obese. To preserve the lean muscle mass for this young lady, what are the advices you will provide?
Well, we don't have any robust tool at the moment that would be able to reduce lean muscle mass. So as we discussed that if you lose weight, we'll also lose lean muscle mass. The good news is that you don't lose muscle power. There are a number of studies that looked into whether you lose muscle power as well, and answer is no. So it's not only SEMA lean study, but look at the STEP heart failure trial. They looked there in subgroup analysis that you know that the primary outcome was 6-minute walk test. Those people who were lost the weight on semaglutide compared to placebo, they were able to walk much better than people on placebo. This suggests that despite you lose body weight, despite you lose say 10% of the lean muscle mass, your muscle power remains intact. Or maybe somebody can say that you perhaps gain some, muscle power. Because if you lose the fat mass in the muscle, you might gain some power. But we don't have any great evidence to suggest that certain therapy would lower the lean muscle mass. We do have some monoclonal antibodies trial, remember, bimagrumab and all that. We do have now trials going on with, amylin agonist. They are also suggestive to be protective on lean muscle mass. Then calcitonin along with GLP-1. There are many, quadruple penta molecules are currently under research that can prevent the lean muscle mass with the GLP-1. However, the evidence what we have that if you start, exercise, especially, resistant exercise, you are able to prevent in lean muscle mass. Now, there is data to suggest that if you increase protein intake, that will also preserve, the lean muscle mass, but we don't have any RCT suggesting that. This is a common sense approach that if you take larger protein, you might be able to protect, simple theory when you go to the gym, your gym instructor says that you take this whey protein, blah, blah, blah. So that's the theoretical aspect of increasing protein intake. There's no data to suggest that if you take supplemental protein, that will protect lean muscle mass. The only evidence which we have at the moment is that if you do the resistant exercise from day one, and once you are on GLP-1, even if you stop the drug, you don't regain that much weight. And data also suggests that the lean muscle mass, loss would be much, much smaller. The two study, SURMOUNT-1 and in STEP-1, those who undergone the resistant exercise from day one, they lost much lean muscle mass loss compared to those who did not do the resistant exercise. So these two data we have at the moment. But beyond that, as I said, the bimagrumab has got their own one trial suggesting that they preserve lean muscle mass loss by 33%. But bimagrumab has got their own problem. Whether this is a CB-friendly drug or not is not exactly known. There are many, MABs at the moment. Tirzepatide is undergoing a MAB trial combinations. Semaglutide is undergoing with a MAB combinations. The problem with MAB is something different in terms of cardiovascular benefit. But they do preserve lean muscle mass, as you know that this is how it works through. But we don't have any great evidence other than the, the exercise, especially the strengthening exercise.
I think Santosh wants to add.
This is another thing that is very irritating to us as doctors when patient come and says, I don't want to take semaglutide because I know that it will cause muscle loss in me. So we have to answer this question very, very, very properly to them. Number one, what is the effect of GLP-1 receptor agonist or GLP and GIP-1 on the muscle? What is the effect? Does it have any direct effect on the muscle? If at all it has any effect, it will improve the insulin sensitivity and increase the glucose uptake at the level of muscle. First thing is, these are the people on Instagram who have lost a lot of business because of the appearance of Mounjaro and Wegovy and the market. These are the people who come and say that if you take GLP-1 receptor agonist, you will lose muscle and you will not lose fat. So we have to first tell them that, see, any weight loss maneuver that you do, whatever you do, you are going to lose along with fat. As Dr. A. is saying, you are going to have some amount of lean muscle mass program, and we are going to tell you how to overcome those problems. Please remember one thing, that this one particular agent is not causing lean muscle mass loss. It is weight loss which is causing. All of them do cause. This has to be driven into the minds of the patients, I feel.
Yeah, I do believe that this is a very common question asked by the patients. So whether you lose weight with diet and exercise or with the medication, approximately 30% loss will be attributable to the muscle and also the lean mass, and hence it is justifiable to suggest some protein intake, more protein, especially in people who lose weight. But they will actually have this muscle get back only if they are doing muscle strengthening exercise. So as a routine in our hospitals, we will provide them with some maneuvers, some training on muscle strengthening, and we have actually one or two staffs training them on muscle strengthening, but this has to be along with the routine aerobic activity. So along with the prescription of semaglutide, never forget about the basic advices to be given in diabetes and obesity, and that is lifestyle management. So this is on top of lifestyle management. So anyway, the person is happy, the lady is very, very happy, and she is also very happy with the physicians because she has been provided with a medication with robust evidence, because she knew that Ozempic could further reduce the cardiovascular events. She already had a atherosclerotic cardiovascular disease, and she has been advised to uptitrate after 1 month, and again after 1 month to 1 milligram. And now moving on to case profile number 3. And this is a 52-year-old, and this is a different case. And she has been battling type 2 diabetes and overweight and obesity for over 8 years. And she has been initiated on a dual agonist. And dual agonist is supposed to be more potent, and she has several episodes of watery diarrhea, which is also a well-known adverse event of a dual agent. And also she is experiencing abdominal pain, which is more commonly experienced with the dual agonist. The hemoglobin A1C is 8.8, the glucose is high. Look at the renal function. So she is in CKD stage 3, 32 ml per minute. And this is a question to Dr. Santosh. She has considered Dr. Santosh, and somebody else has started her on a dual agonist. Are there clinical reasons to prefer a monoagonist? And this is the world's #1 GLP agonist, currently used by more than 70 to 80 lakhs people. And why not prefer Ozempic over a dual agonist, and what are the reasons? If you are preferring Dr. Santosh, what are the explanations for that?
If you keep science aside, it's #1 reason why we'll shift from tirzepatide to semaglutide is if the patient says, Dr. Saab, I like to use this, but I'm not able to afford it. So as far as cost is concerned, we have a GLP-1 receptor agonist now, which is more affordable. Second thing is, as discussed in many scientific conferences, watery diarrhea seems to be much more common with tirzepatide use, although we don't have phase 3 data which suggests that this is more common in this than that. But watery diarrhea in our clinical use seems to be much more with dual agonist, and therefore shifting them to an Ozempic, the people seem to do better as far as that side effect is concerned. But yes, what we are here to discuss this, as far as label is concerned, Dr. Avdesh Kumar Singh's beautiful slide which he has prescribed, it is the only agent, that is semaglutide, that has been approved on label to protect against cardiovascular disease. I mean, when you compare to both these agents, and it has been there to protect it's helping in preventing kidney outcomes also. In this particular lady, the EGFR was low. So it is a label to protect adverse kidney outcomes and death due to CV cause, and also all-cause mortality in these particular patients. And especially in patients with fatty liver disease, MASLD also, it has an indication to show that it actually prevents the progression of fibrosis in many patients. So if there is a hard indication in which I want to prevent 1, 2, 3 programs in which especially semaglutide has good data on, I would prefer to use this particular agent rather than the dual agonist.
Fantastic. So Dr. A.K. Singh has presented data on 26% reduction in the major dose cardiovascular events in SUSTAIN 6, then FLOW clinical trial. You have ESSENCE again, data on steatohepatitis and fibrosis regression without progression of steatohepatitis, and regression of steatohepatitis without progression of fibrosis. So it is already an FDA approved therapy for to be used in MESELD and MASH. And hence the label, the indications are much more. and you have an approval for many more indications for semaglutide, and legally also you are more protected when you are suggesting semaglutide. But if your intention is only for a weight loss of more than 30 kilogram or 40 kilogram, and your intention is not to protect the kidney or the heart or the liver, then probably the other agents will be of your choice. But for your patient with diabetes, with diabetes or obesity, the first choice should be the innovator molecule, and that is Ozempic or Wegovy. So let me continue. Considering that Ozempic has an additional on-label indication for risk reduction of renal outcomes, the dual agonist has been stopped by Dr. Santosh, and Ozempic has been initiated, and she has been counseled on how to initiate, how to titrate, and so on. So let me now invite a couple of questions. We have 2 or 3 more minutes. Any questions from the audience to the elite panel, Dr. A.K. Singh and Dr. Santosh? Yeah, please, sir.
Sorry. If the loose stools continue and patient has vomitings also, so how do we handle it? Do we stop the medication, or how do we? We are going slow, of course.
Yes, so
Even in spite of semaglutide, the
Of
loose
course.
motions are continuing. Patient has got panicky.
Yeah.
So how do we do it then?
yes, so let me tell you two things. Semaglutide cause more constipation than diarrhea. Tirzepatide cause more diarrhea than constipation. There is a reason behind that. The GLP-1 delayed gastric emptying, and therefore it causes constipation. Once you add a GIP, the GIP is a prominent large intestinal secretagogue. GIP promotes intestinal secretion and causes diarrhea. And therefore, tirzepatide causes more diarrhea than constipation. That's very clear finding, and there is explanation as to why tirzepatide causes more diarrhea than constipation, and why semaglutide causes more constipation than diarrhea. Now, if your patient has got a diarrhea, which is of course not manageable by conventional therapy, we have two things to look at. Either we can don't titrate the dose from whatever dose she or he is, and of course you might get that this problem is gone. Or you can temporarily stop the drug and then you restart with a step down approach. If your intention is to prevent cardiovascular and kidney disease, simply stopping would not do the job. When a GLT2 causes balloonoposthitis, we never stop it for a whole life. We stop it for some time, we give a conventional antifungal drug. Once the moment is off, when the problem is gone, we restart the GLT2 inhibitor. Similarly, if the GLP-1 is causing diarrhea, which patient is not able to tolerate, not managed with the conventional anti-diarrheal drug, blah, 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 there is no need to panic. You can stop the drug or you can step down the drug, but keep in mind that the purpose will not be served if we stop the drug for the future.
Thank you, sir.
With so much robust data, cardiac and renal, diabetic with normal body weight, can semaglutide be given?
Of course. So for Ozempic, indication is not body weight. Let's not confuse. When we are talking about Wegovy, that is an anti-obesity drug. Ozempic is an anti-diabetes drug. So when we are talking about semaglutide up to 1 milligram, this is for diabetes, regardless of body weight. So there is no doubt about that. So if you have got a patient with diabetes, and if his BMI is larger, of course it will do a dual benefit. But it doesn't mean that if you have got a normal BMI type 2 diabetic patients with a history of heart disease, you should not prescribe semaglutide. You must prescribe semaglutide regardless of his BMI if he has got a high cardiovascular.
Thank you.
Patient has taken 14 milligram of the oral semaglutide. Am I audible?
Yes, we can hear you.
14 milligram of the oral semaglutide, want to go back to injectable because non-responder. 2 questions, how to convert and what result we expect by injectable compared to oral.
Right. So we do have data to suggest that 14 milligram of semaglutide produce similar plasma semaglutide exposure compared to 1 milligram semaglutide. So if your patient is currently on Ribelsus 14 milligram and you wish to shift him to, or patient preferred to go to injectable because it's once weekly, you directly shift from 14 milligram to 1 milligram semaglutide.
do we expect different result with the oral and injectable because oral bioavailability may be different?
Well, so we don't have any direct head-to-head randomized control trial between oral semaglutide 14 milligram and 1 milligram of semaglutide, but we have a many real-world studies where 14 milligram semaglutide was compared to 1 milligram injectable semaglutide. There was no difference in HbA1c as well as body weight as well as GI side effect between oral 14 sema versus injectable 1 milligram. So I have published few papers on that. How many trials has been done where the 14 milligram was compared to 1 milligram. The data suggests that both are equal to each other in terms of efficacy and safety.
A very, learning experience talking to you.
Thank you, sir.
But basically, the India is a country of jugards. So, a week before, I encountered a patient whom I suggested semaglutide oral medication, and he came to me after 2 months, and he told me a unique thing. I want your response on that. कि डॉक्टर साहब मेरे को कॉन्स्टिपेशन हो गया था और नौजिया हो रहा था बहुत, उल्टी भी आई, तो मैंने एक दिन छोड़ के एक दिन मेडिसिन कर दी, and still I found it that I am having side effects and I am taking now every 2 days and still I am losing weight. And his diabetes is optimally controlled with additional of SGLT2 inhibitors. And what should I suggest him? That you should take medicine regularly, or it is good that you are taking every 2 days and still you are getting good results of losing weight. Because we have seen non-responders, we cannot break the tablet and ask him to do a half tablet a day. So that is a unique thing I have encountered in 2-3 patients.
It might happen, and this is not surprising. So we would not recommend him, his or her, to do same thing, that you take it alternate day. But if, as long as it suits your patient, as long as it do not increase her HbA1c or hampers in body weight lowering, she can take it. But that's an off-level advice. And it happens in clinical practice. I do agree with you.
I have 2 questions. The first one, if we are using Ozempic for normal body weight, normal BMI, diabetic with having cardiac risk factor, will there be a concern of weight loss to that person? And treating physician also, he will again lose the weight. Person with BMI of 21 or 22 taking Ozempic, and he further reduce the weight, whether we should continue it for cardiovascular and diabetic benefit or we should stop it. Second question, we are using semaglutide pens of higher doses and giving a lower doses by counting the clicks. Because 60 clicks will give 0.5 mg 0.5 pen, and by giving 60 clicks, it will deliver 0.5. If you are giving 30 clicks, it will give 2.5. To reduce the cost of the patient, and pen will last for 2 months. The cost will be reduced to half. Can we do these jugars, and can we continue that semaglutide in a normal normal body weight person having weight loss?
I think we should close the discussion because we have now started discussing jugars in a scientific case. So I think we should stop that. The first question is good. So there is a absolute category called as sarcopenic obesity. If you go to the guidelines and see how to manage sarcopenic obesity, where the person is already having a normal BMI, we are mainly concerned about his visceral fat and cardiovascular protection. What is the amount of protein he needs to take? What are the exercises he needs to do? There's one nice article that's there in Obesity Journal. Please read that. It'll tell you how to manage the different patients with on GLP-1 receptor agonists with different BMIs.
Regarding this lean muscle mass loss, is it due to direct effect of the molecule or indirect effect as other proteins and along with the carbohydrates, protein loss also will be there? Is it a direct effect or indirect effect? Another thing is interstitial muscle fat. It may reduce along with the weight loss. That may be the reason, because as you said, power is retained, but mass is thinned. So what is your experience?
So it's not a direct effect of the drug. See, it's not GLP-1. If you lose body weight by any means, be it a lifestyle, be it a drugs, be it a bariatric surgery, you will lose everything in different proportion. While we don't want to lose lean muscle mass, we want to lose all visceral, adipose tissue, subcutaneous fat mass, but then you cannot, if you treat patients with insulin, you cannot only control prandial blood sugar. Fasting will also come down. This is how the nature, protect us. So it's not a direct effect, it's a generalized effect. Regardless of the nature by which you are reducing body weight, everywhere there will be reduction in the lean muscle mass. Now, as you said, this is perhaps interstitial fat mass loss. This area is still looking at, and I hope in the future we'll be able to crystal clearly know that what is happening in this space. The good news is that if you are doing the resistance exercise, you can protect your lean muscle mass. That's it.
So it has been a learning experience for all of us, very clear messages. And in addition, remember the fact that Ozempic and Wegovy are global blockbusters and been there for almost close to 10 years. And everybody with diabetes or obesity, I can say that the information is available in the internet, in the public domain. So it is our responsibility to document whether they accept a prescription or not. Document that you are suggested and they have denied it, you document it, because otherwise the doctors can be in trouble. Because this is a record molecule, because nowhere in the history of diabetes, as Dr. A.K. Singh has said, we had such a molecule with these many benefits. So let us give a standing ovation to both the panelists. Fantastic.
Thank you.
Thank you.